Good evening, everyone, and welcome to CESPHN's immunisation update for 2022. My name is Brooke. I'm part of the immunisation team at CESPHN, and tonight we also have from CESPHN Mimi Campbell and Kira Wright, who are the other members of our immunisation team, and also Dr. Brendan Goodger, who is the Manager of General Practice Improvement. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respects to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. So without further ado, I'd like to introduce Dr. Brendan Goodger. Brendan is, your name exactly correct here, Brendan, the General Manager of Primary Care Improvement within CESPHN. I'm going to pass you over to Brendan.
Thank you for that. Can everyone hear me? Can you hear me? I think I'm on mute.
No, we can hear you.
Okay, thank you for that.
We can hear you, Brendan.
Thank you. The mute button got me again. So look, welcome everybody, and thanks, Brooke, for the introduction. I just want to give you a bit of an overview about what we're doing here in CESPHN and also highlight for you some of our concerns. Firstly, to note that the Omicron subvariant, BA.2, is on the rise, and it's significantly more transmissible than the original Omicron strain. I guess we've had a real journey with COVID, haven't we? Particularly over the last 3 or 4 months. From December the 15th, when some of the public health restrictions were relaxed, we had a significant severe outbreak of Omicron. We had lots of aged care facilities that were in lockdown, and we had a real increase in COVID cases within our community. And what's happening now is that BA.2 is now replacing, if you like, the original Omicron strain. It's a lot more transmissible, and we can see that as it sweeps through schools, and increasingly we're seeing it impacting aged care facilities. We also want to highlight to the issue about COVID fatigue or COVID complacency. It is a major concern, and it's a major concern because more and more people are catching COVID, and we know that long COVID is a consequence for many people of catching COVID. So what we want to try and do is take some of the pressure off the healthcare system. We want to try to reduce people catching COVID. And we also really want to promote the issue around vaccination, which of course all of us are committed to. There's also a number of key things that I think people can do to try to protect themselves, their loved ones, and the people that they see. And so just a reminder that healthcare practices are still a high-risk setting. Just because COVID is out there in the community now and widespread, it doesn't take away from the fact that healthcare practices are a really high-risk setting. So we would encourage our general practice staff that they should continue to wear masks in the workplace. They should continue to remain extremely vigilant around infection control. And again, just to emphasise that patients, staff should be wearing masks, okay? And I know that New South Wales Health has put out some communications, as have our PHN. Next slide, Brooke. This next slide simply highlights that, well, in Australia at the moment, in the last 7 days, whilst we had an uptick in the number of COVID cases, we're not seeing that many deaths. I think it's about 151, and certainly we're a lot better positioned than many other countries. Just to note, though, that the number of daily cases per million, you can see that Australia now has 1,641, as opposed to some of the countries like Canada and the United States. I think it does show, though, that internationally that we are seeing an upspike, if you like, or a spike in the number of COVID cases within our community. Next slide. It's important to remind ourselves and around the uptake of booster vaccinations. We know the protective impact that booster vaccinations can have in reducing the severity of COVID, but also reducing long COVID. We have about 50% of our Indigenous populations have received more than 2 doses. In terms of the rest of our community, there's now nearly 66.4%. So there's still that gap that's of concern. And what we are trying to do is really encourage Indigenous people to receive the boosters. Pleasingly, and after an awful lot of hard work, we've now got nearly 93% of aged care residents, who are some of our most vulnerable people in our community, have received more than 2 doses. And that's been in itself a huge achievement. And you can see there also that people with a disability have also substantially lower rates of uptake of the booster vaccination, and that's an area that we do need to concentrate on. I won't go through the different state percentages. They're fairly self-explanatory. You'll note that New South Wales is 62.3%. We can do better than that, as opposed to the ACT, that's now tracking at not far off 74%. And of course, WA, slow starters, but they'll really come on strongly at just over 85%. Next slide. This next slide is an interesting one. I think what this next slide shows really is again the vaccinations by state of the last 7 days. And I think what's really important in the slide is it shows you what's happened in terms of who's actually administering the doses over the last 7 days. So of the 160,000 vaccinations that have been delivered in total, 131,180 have been delivered by primary care. And I think primary care deserves a huge clap, quite frankly, for the work that it's done in vaccination. It has shouldered the burden of the vaccinations in Australia. It has done extraordinary efforts. And you can see that in the data that's in those graphs. And again, just to note that 131,000 of the 131,180 doses out of the 160 doses have been delivered by primary care in the last 7 days. It's an extraordinary effort and one we should be proud of. Next slide. I'm not going to comment on this too much either, but this slide is actually a real concern for us. You can see here the COVID vaccinations in our region for those who are 16 years and over. And I think what's concerning here is the proportions of people who have received more than 2 doses. It is substantially less than what we would like. In other words, we think there is a need to really try to increase the number of people receiving booster doses. It is lagging and it's not where we want to be at the moment. We want increased numbers of people to get their booster doses. And if it's one of the key messages from tonight to you all, it's around really trying to encourage booster doses. And you can see the particular locations. We see that, for example, Canterbury Bankstown has a particularly low proportion of people who've got more than 2 doses. It's high in some areas, like Wallara, like the inner west, but it's certainly lower in Canterbury, Bankstown, Bayside, Strathfield, Georges River, Waverley and Sydney. So these are areas that if you practice in those areas, we'd really encourage you to reach out to your patients who haven't had those booster doses. Next slide, please. I'm going to let Brooke talk a little bit more around this, but we know that COVID, particularly BA2, is sweeping through the schools at the moment. And we're really keen to encourage those children aged 5 to 11 to get their doses. And once again, this does show some geographic differences across our area. And once again, we've got Canterbury Bankstown at just 34.1%, as opposed to Sydney, the inner west, Wallara. I wouldn't say quite double, but not far off that. So they have significantly more people children being vaccinated. So really want to give a bit of a shout out tonight for all of you who are practicing in those areas where the vaccination rates are not quite where they should be, particularly in Canterbury, Bayside, Georges River, Sutherland and Canada. That's, again, I think a really important message if you are living in those areas. Next slide, please. Just to give an overview of the practices who are participating in the vaccination program, we've got 426 general practices who are participating in the COVID-19 vaccination program, and we've got about 605 practices in our region. Okay, so that's about 426 out of the 605. We've got 199 practices who are now approved to administer the Novavax vaccine, which is great. If you need, and Brooke has made this point, I think, but if you need more or that you have excess COVID-19 vaccine stock, then please contact CESPHN to facilitate transfer. We're really keen and pleased to help you with that. I've already mentioned the issue around trying to improve the vaccination rates in children aged 5 to 11. Can I also indicate too that we also run a Vax at Home service to encourage vaccinations for those people who are housebound. We've got a nurse who will go out and vaccinate those people who are housebound and who can't leave their house and therefore can't get a vaccination. So we're really keen to support those people and make sure that they get protected. So email us and we will contact you and make provision for those people to be vaccinated. Next slide. Look, just in terms of aged care facilities update, we've got 161 aged care facilities in our region. I think all of them have had COVID-19 outbreaks. Some have had as many as 10 outbreaks. I think what's really important is the role of vaccination and protecting particularly vulnerable older people in those facilities. So on the 1st of March, New South Wales mandated COVID-19 booster vaccinations for all aged care workers by the 12th of April, or 6 weeks from the due date of the booster. And we're also asking COVID-19 vaccination general practices, they're asked to really prioritise aged care workers for the booster vaccination. And I think that's really important that those aged care workers get their vaccinations. And again, if you get one in your practice, then really try to prioritise them if you can, because we know that one of the greatest sources of transmission into aged care facilities is through aged care workers. That's probably it from me. Brooke, happy to hand back to you.
Thank you, Brendan. And just letting everyone know, there's no questions that have come in for Brendan at the moment, but please feel free to add your questions there if you think of something pertinent later on. And if the girls don't have the answer for you directly, they will let me know, and Brendan will be around the whole presentation so we can ask him those questions at the end. So our main presenter for this evening is Associate Professor Nicholas Wood. Nicholas Wood is a staff specialist, general paediatrician and Associate Professor of Discipline of Child and Adolescent Health at the University of Sydney. Nick leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital in Westmead. He's a senior investigator on the Primary Health Network Immunisation Support Program too, which is incredibly helpful for us as a PHN. So I'm going to welcome Nick. Nick, I'm going to stop sharing and you're welcome to share your presentation. And again, please put your questions in the Q&A section and we'll answer them either live or online.
Thanks very much, Brooke, and hello everyone. I hope you can see. Whoops, we've got to go to the start. That'll be a good place. Yeah, I hope everyone can hear me all right and see the slides. So thanks very much for having me. And it is an ongoing busy period for all of you guys at the front line for sure. So in the next little while, I wanted to try and cover these topics and we'll hopefully have some time for some questions. So a little bit more about where we are with COVID-19. And as Brendan mentioned, I think there's probably a vaccine fatigue out there, which is, you know, coupled with hesitancy as well. And we might address some of those thoughts and be interested to hear from you guys what you think is happening as well. And then to touch on to some non-COVID things, such as the upcoming flu season, which we may or may not have. And just when we thought that we would only have one zoonotic infection, along comes Japaneseencephalitis. So we'll talk to you a little bit about that. And then finally, some just to remind you about the non-COVID vaccines and to, you know, because it is core work, what's been core work for many years. As Brendan mentioned, really the story today across the world is the Omicron variant, and this just shows how dominant it is now as the strain that is circulating around the world. As Brendan also showed, it is across the world, but the wiggly black line there, it's deaths. And you can see that way back in November, December, when there were peaks of cases, the death rate was quite high, but the cases now, you know, if we had the equivalent severity with the Omicron strain, the death line there would be much higher. So it is in some ways lucky that although it's more transmissible, it's certainly not as severe. And this is some data out of the UK where they tried to compare the Omicron variant versus the Alpha or the original strain. And you can see here that the new cases is the blue line and it's going up. But in terms of hospital admissions and deaths, it really hasn't seen. So there's this sort of decoupling, if you like, is what they're terming it. That although it's more transmissible, it's certainly not as severe as the previous strains. And it may well be, some people are saying, the final part of the whole COVID story, in that if it becomes less severe, more transmissible, we all get natural immunity and it becomes like the common cold. Having said that, though, there are many vaccines that still remain in development, and this is just a sort of a pipeline of where they're at, with 23 vaccines in use, and phase 4 means they're sort of being actively used around the world. And the 3 that we have is the AstraZeneca, the Pfizer, or the Moderna, the Spikevax, so the mRNA vaccine, and the Novavax protein-based vaccine. So a little bit on Novavax or Nuvaxovid. It is a protein-based vaccine and essentially is the purified spike protein with an adjuvant, which is a sapinin adjuvant, so a soap from the bark of the sapinin tree. It's been registered for a primary course for those aged 18 years of old and older, 2 doses with a minimum of 3 weeks apart. And it can be given to those people that have previously had SARS infection, and we'll say a bit more about that later. Immune suppressed people can receive it, as they can the mRNA vaccines. And you can give it as part of a mixed primary schedule, but there's not much experience with that. And as you've heard recently, it's approved as a booster dose if no other vaccine is suitable, and can be co-administered with other vaccines. So Novavax is the new kid on the block, Nuvaxovid. It's certainly nowhere near used as much globally as AstraZeneca or Pfizer, which has now had hundreds of millions of doses given. There's a little graph, a little table here down in the right column. I'm not sure if you can see my arrow moving, but this little figure here, which is entitled COVID-19 Vaccines in Australia, we've put a link in one of the slides here. I encourage you to have a look at that, because it is quite a useful sort of all-in-one stop place, each of the vaccines, and a whole lot of information about the storage of them, the diluents, etc. So make sure, if you there'll be one take-home message to have a look at that. It's quite a nice little pamphlet. So that's a little bit about Novavax. Because there are, as shown in this graph or this table, lots of different vaccines, there is the potential for errors. And we've seen these coming to our service, such as children being given the adult dose, adults being given the pediatric dose, some people being given a whole vial rather than the correct volume from the vial. Vaccines that, as you know, there's a very complex storage to them, which has probably got less complex as we've gone on, but issues with the cold chain, and certainly talk to PHN about that. Some vaccines being given inadvertently to kids under the age of 5, incorrect dose intervals. So these are all the sorts of things that you would expect to happen and have happened when you're administering a vaccine program for nearly 30 million people across the country. So when it does actually happen, obviously the things to follow are to inform the recipient that there has been an error. There is a very nice ATAGI guidance document, which again is a nice take-home, one of the things to remember to have a read in your spare time. It's based on a very nice document out of the CDC, where they tell you what to do in the case of, for example, where a pediatric dose is given to an adult, etc. So have a look at that clinical guidance document, and as you would expect, when there has been an error, important to understand why it may have happened and to prevent it happening again, and then tell New South Wales Health, and then they often refer you to the VOC as well. So that's a little bit about that. The latest thing that we've started in the last sort of 2 months has been the vaccination of the 5 to 11-year-olds. And as you know, there's 2 vaccines available now. There's the Pfizer vaccine, which is a pediatric dose of 10 micrograms. The standard is 2 doses given 8 weeks apart. Interestingly, that is different to the clinical trial, where the vaccine in the clinical trial was given 3 weeks apart. Now, many other countries like Canada and the UK have gone with an 8-week interval. And there are benefits to that, such as probably a slightly better immune response, and probably also a slightly lower risk of myocarditis. And that's what that graph down here is showing. This is Canadian data, where they've looked at the incidence of myocarditis depending on the interval between the doses. And it just appeared that if you had a longer interval, such as an 8-week interval, you were less likely to see myocarditis. Now, the myocarditis story in adolescents, as you may or may not have experienced in your practice, is fairly common in that 16 to 20-year-old age group. And it's usually dose 2, and it's usually after the Moderna or the Pfizer vaccine. We've been following this in the 5 to 11s, and we're not seeing this sort of myocarditis story in the passive surveillance system. So that's really important, I think, because everyone was worried that we would see myocarditis in the 5 to 11s, but we're just not seeing that there. Another really useful brochure that you can find on the COVID-19 vaccination is, there's one here for Pfizer and there's a similar one for Moderna. It's a 2-page brochure, and it just, little memory jogs about what to make sure you get right when you prepare and administer the vaccine. So again, a nice, useful, and what I'm sure the PHM will be directing you to these links again, but you'll have the talk to have a look at. So just a little bit of a flag for that particular infographic, which is very helpful. So yes, Moderna is another option for the 6 to 11s. Now you notice it's 6 in bold because it's registered for use from 6-year-olds. So the 5-year-old kids, they need the Pfizer. Okay. It's a pediatric dose. It's a half of the dose of the adult version, which was 100 micrograms. So it's a 50 microgram version. Again, 2 doses, 8 weeks apart. It can be given with other vaccines. I'm not sure how much that's happening in practice. And there is this dot point there about children who get the first dose at the age of 11. and then 2 to 3 months later, they're now over 12, they should then get the adult dose. That's what the recommendation from the ATAGI document is. So that's the Moderna, which is called Spikevax. It is half a dose, as I said, but it is actually the same as what we use for the booster dose in adults over the age of 16. Now, so that's the rollout of the pediatric program, the 5 to 11s. For the under 5s, the 2 to 4-year-olds, it is still in play in the clinical trial environment. So they lowered the dose again down to 3 microgram dose. And I think they've discovered that they probably needed 3 primary doses. So they might have undercooked the pediatric dose for the 2 to 4-year-olds, maybe not quite given them enough antigen. And so they're still trialling that. So I don't think we'll see a 2 to 4-year-old program for a little while yet in Australia. However, as Brendan mentioned, the boosters are an important component. And this schematic here is designed to sort of illustrate what we've experienced. So as you know, last year we had the 2 primary doses. That gives you this red line going up where you get immunity and you get protected. Along comes the variant strains, and as our vaccine-induced immunity wanes, and the red line starts to come down, we get below this threshold of protection, we get a breakthrough infection, and that's the blue line going up. And that's what we're seeing right now at the moment. We then give you a 3rd dose or a booster dose, and hopefully the protection climbs. And then probably what will happen, which I'll show you in a minute, that protection may also start to wane as well. So there is, that's the theory, and that's what we're sort of seeing play out in real life. We don't have, unfortunately, a magic threshold of protection above which we can say, if you make antibody to this degree, if your antibody level is this high, that you are protected. We just haven't got that threshold available at the moment. So which booster dose? And I'll show you why in a minute. So ATAGI has said that everyone aged 16 years and over should get a booster dose. Now, as you know, the immune suppressed group were always recommended to get 3 primary doses and then to give a booster dose. And that's that last dot point there. If you're immune suppressed, you get 3 doses as the primary schedule, and then you get that booster 3 months after the 3rd dose. Okay. The ATAGI has said that mRNA vaccine is the preferred, but Pfizer is really only registered for the 16 years plus. AstraZeneca can be given if the person had an adverse event after the mRNA vaccine. Okay, and Novavax can be used as a booster dose in those over the age of 18. And we talked about that immune suppressed. So again, the ATAGI guidance is this is an attempt to summarise that for you. Okay, so this is what we've been seeing from the UK, and in this little dots here are the effectiveness after dose 2 of the Chadox, which is the AstraZeneca vaccine, and the dark squares are the Delta, and the open circles are the Omicron. And you can see when if you can read it, when you get out to the sort of 25-week plus mark after your 2nd dose, there's pretty much very little effect at all from the Chadox vaccine against the Omicron, okay? For the mRNA vaccine, the similar sort of thing, protection against Omicron around about the 6-month mark, drops to about 20%, okay? So that's, and that's where we're in the Omicron space at the moment. When they then give a booster, you can see that it climbs back up, and that's illustrated better in this slide here. When you get 2 doses of AstraZeneca and then you boost with an mRNA or a Spikevax, you can see that the Omicron protection climbs, and there's a hint that it starts to fall again, okay? If you've had 2 doses of Pfizer and then you get a Pfizer booster, you can see that protection climbs, and there's a hint that it also starts to wane over time. So there is, this is against hospitalisation. So there is data out of the UK, and this is why there's a big push to make sure that we can get our booster doses in, to up our week. The take-home messages here are that one, the protection from 2 doses really starts to wane from 25 weeks post the second dose. That's point number 1. Point number 2 is that a booster dose with an mRNA vaccine like Pfizer or Moderna will improve your protection against COVID hospitalisation. And it bumps it up, as you can see here, around about the 80 to 90%, but it might well start to wane again. Now that comes to the next story, which is later on. What do we do for 4th doses, etc.? And that's why Israel has embarked a little bit on the 4th doses. But the take-home message is for you guys, if someone says, well, I've had my 2 doses, do I really need the booster? You can say, well, it's now been at least 24 weeks since your second dose. Data from the UK and the US and other countries like Qatar has suggested that the protection against hospitalisation for Omicron really wanes, and a booster will give you more protection. So this is the looking in adolescents, and this is, you know, we're not yet boosting adolescents, but this is the protection for the adolescents. And you can see that 12 to 15-year-olds, again, time after dose 1 here starts to wane. And this just shows you that when you get a booster with all the second dose in the adolescents, you get the kick up in protection. So, and it takes about a week or 2 weeks for the antibody to be made. So this little graph here on the left is trying to illustrate the importance of the second dose in the 12 to 15-year-olds. And this graph here is showing the same importance of the second dose in the 15 to 16-year-olds. We just get that boosting. It's the same idea. So that's the importance of the second dose. So this is trying to summarize it for you. Omicron, look at the top table here. By 4 to 6 months, you know, after dose 3, if you had the booster dose, the 3rd dose, you've got a 40 to 50% protection against symptomatic disease, and hospitalisation about 80%. Okay, so that's the sort of take-home message, really. The UK is thinking about what they're going to do prior to their winter, and the same discussion is being had in Australia as well. Do we or should we give our 4th dose to those people who are high risk, immune suppressed, etc.? It's not yet decided in Australia, but it's being watched closely. There are Omicron specific vaccines that are under trial. There's a range of companies making, for example, a monovalent one. There's also bivalent ones that have got ancestral strains and Omicron as well. So I think I've labour that point a little bit, but that's the need or the importance of the boosters. Now, we heard a little bit from Brendan as well about the BA.2. Now, that's the new sublineage of the Omicron. BA.1 was the dominant one. And so people are now looking at, well, what is the vaccine effectiveness against BA.2? And this is some early data out of the UK. And you can see here the dose 3 and the round about the 10 weeks mark after dose 3. The vaccine effectiveness against BA.1 and BA.2 is around about 50% against symptomatic disease. So it's suggesting that although BA.2 is now, you know, overtaking BA.1 as the lineage of concern, it doesn't appear right now that the vaccine is not working, that there is still some vaccine effectiveness, which is good news. Obviously, we might find that there's a new variant that comes along over time. Okay, so that's a little bit about where we're at with the COVID vaccines. I just want to sort of take you to some of the issues that Brendan mentioned about the uptake of the 5 to 11s and the booster uptake. There's a whole lot of information. There's probably too much information to get your head around, but you can direct people to the NCIRS. It's got a whole range of COVID fact sheets and FAQs. We're running seminars that might be able to, you can attend, that might just answer some of the current, they're designed to be seminars that are current hot topics. And there is a weekly JAB newsletter where you can get information, and the PHN support program as well will provide the PHN with the latest information that can be sent to you guys as well. So most people, in terms of the people that want to get vaccinated, there's sort of those that are ready and don't question it too much and go about giving it. There will be those that are a bit hesitant, and I think the approach there is, as you all do, is to just ask, listen, understand, acknowledge and validate. That's really the sort of the mantra. And there's a whole lot of information that you can access. The Sky, just to plug the Sky website, there's lots of decision aids there and useful tools. So you can, and the Sky is used for the actual public. So you can direct people to that one. So as Brendan mentioned, the coverage across the country is around about 51%. And we heard today that it's 51% for dose 1, and for dose 2 nationally, it's 17%. Now, admittedly, the dose 2 program, or the people that are eligible for dose 2, is just starting now, but it means around about half of the 5 to 11s have not yet even had dose 1. And you can see here that there's a gradient between 5-year-olds to 11-year-olds. Those that are nearing high school entry are higher at 58, 55% compared to those that are just starting primary school at the 40 to 46% mark. The other thing we know about the coverage in the 5 to 11s is that it is lower in the lower socioeconomic areas and also lower in the culturally and linguistically diverse areas as well. So the challenge is, what do the parents want to know to increase their confidence to get the COVID vaccine? So NCIRS has a couple of decision aids. There's one for the over 16s, and there's a specific one for the 5 to 15-year-olds. And you can access them on the NCIRS website. This is sort of how it works in practice. You go on to the parent can go on, they can tick one of these boxes, and then it opens up a whole range of things. It really compares the disease to the vaccine, and they have a look at it graphically like this, where you can see the symptoms you might experience from disease versus vaccine, and then the other sorts of side effects of the vaccine. So that is one useful thing for parents to have a look at. That might just help them, improve their confidence to get vaccines. I think part of the equation too is that we estimate that, perhaps 1 in 4 households in New South Wales, or certainly in the metro region, has had COVID in their household. And so a big proportion of those people that are not yet vaccinated are probably because they either just had COVID, and therefore waiting until they've completely recovered before they go and get a dose of vaccine. So what are the benefits of vaccinating a child? And it's explained at the public terms in the decision aid, but there are, I think, the direct benefits to the kid to stop them getting severe illness. And I'll show you in a second the types of kids that are particularly likely to get severe illness. There is this PIMS-TS, which is this post-infectious inflammatory syndrome. And the Americans call it MIS-C. And there is probably a potential for long COVID, although, to be honest, the degree of long COVID experienced by children is not very well quantified. Other benefits to the child being vaccinated: if they're less likely to get the disease, they're less likely to, miss out on school and other life disruptions which they've had to put up with for the last year, really. COVID, if you want to read a nice paper, there's this paper on the, which is table on the right here, which you probably can't quite see all the detail on, but it's a paper published in JAMA. Japaneseencephalitis is the author, and it really describes the risk populations that are most likely in children to get sick. And that includes those with diabetes, obesity, and cardiac problems. So they're the top three, really, that are the ones that are going to be getting sick with COVID if they get infected. So that's the issue about the vaccine hesitancy. In terms of what we know about the safety of vaccines, there's a Ausvac safety website, which I'm sure you're all accessing or having a look at. We've now got a lot of data on the vaccines, Pfizer 1, Pfizer 2, Pfizer 3, with several million people filling out surveys. And these are fairly easy graphics for people to read and understand. And it talks about the side effects that are most commonly reported in the week after the vaccine. And I think, you know, in terms of the booster dose, what we did see was that Pfizer 2 was more reactogenic than Pfizer 1, but it appears that Pfizer 3 is about the same as Pfizer 2 or slightly less. So it doesn't appear to be, you know, Pfizer 1 was bad, Pfizer 2 worse, Pfizer 3 even more worse. That doesn't appear to be what we're seeing in real life. So I think that might reassure some people that, you know, the booster or the third dose does not make you feel any worse than the second dose. And that's data from nearly 400,000 adults that have had a third dose and reported it. This is the Novavax data. You can see not many reports there. We're starting to gather more as it comes in. Local reaction, fatigue and headache, joint pains are the common sorts of things that people are reporting after the first dose of Novavax. Very similar to Pfizer and AstraZeneca. But we'll get more data on Novavax as it comes in. And as I mentioned earlier, in terms of what we know about the vaccine, we know much more about the mRNA vaccines, particularly Pfizer, compared to Novavax. So the children's safety data, there is Ausvac safety data, and here's the most recent. You can see here 124,000 people have reported the types of common side effects that they get: fatigue, a bit of headache, a bit of sore arm, etc. Importantly, not many having to go and, you know, get medical help in the first few days. A little bit more commonly after dose 2, which is sort of mirroring what we see with the adults. There's 10% here, and in this figure here in the adults, it's about 20%. So in general, the 5 to 11s are a little bit less likely to see side effects than the adolescents and the older adults with the Pfizer vaccine. And it's, mind you, it's a lower dose as well. So that might be part of the reason why. So you can reassure, or people can be directed to having a look at the Ausvac safety data, and particularly click on the links for the children's data. So that was what I wanted to talk a little bit about with the COVID story. Just moving on to non-COVID things now. The influenza season, that, look, to be honest, we really haven't had flu around for at least the last 2 years, and definitely the last 1 year. You can see the red line down the bottom there, which is the 2021 flu season. It really didn't appear at all. Now that's because a combination of, you know, social distancing, people wearing masks, hand washing, etc., as well as the fact that there was no or little international travel to allow the virus to move from north to south hemisphere. Now, what happens in 2022 is hard to know. This is the flu tracking. You can see the going back to 2019 here on the left-hand side of the graph. This is respiratory illness, which is probably this is picking up the Omicron surge where there's fever and cough. But in terms of the flu burden, we really haven't seen any flu much at all. So it's hard to know what will happen this year. There's a few sort of pointers to give you, in that people are now mingling more, meeting more. The meetings are back on, schools are back on, density limits have been removed, domestic borders are opening up, international travel is opening up. We had poor uptake of flu vaccine last year, particularly in the children. It dropped by about 50%, the uptake in the children. So it's hard to know what's going to happen this year. It might well come back. The other important point is that a child born 18 months ago has really got no natural immunity to influenza because it just hasn't been circulating. So they really are a naive population. Their mother wasn't exposed while pregnant, so they don't really have much in the way of any natural flu. So they really are, under 2s are particularly vaccine and flu naive, and they might well get a nasty flu. Hard to know what's going to happen, hence the picture of the crystal ball there. So this is the strains that a bit hard to read, but the strains that are in the 2022 flu vaccine, and the usual graph that's available on the Commonwealth website with the age and the particular vaccine brand that is applicable for use in that age. So I'm sure the PHM will be sending you around these when they're available and ready to go. Like I mentioned, particularly in young children, the flu coverage fell from about 50% to 25% last year. I talked about there being a low immunity to flu. You can give COVID and flu vaccines on the same day. For those over the age of 65, Fluad Quad is the preferential vaccine. Vaccinating prior to April, or from April onwards really, when it becomes available, is probably still the preferred thing to do. There's always have these discussions every year, should I vaccinate now or later, when's the flu coming? I think for this year, we don't know when it's coming. It may not come, but if it does come and we've got flu and COVID circulating in winter, we might have a bit of trouble. ATAGI advice on the flu vaccine is now available, and I'm sure the PHN has been circulating that through, as well as a whole range of New South Wales Health documents for providers as well. In terms of co-administration, ATAGI guidance on that as well. You can give flu and a COVID vaccine on the same day if you want. There's been a fair few studies around the world showing that the immune response is not diminished if you do give them on the same day. Now, there might be a little bit more reactogenicity because you are giving 2 vaccines, so you just need to tell people about that. If the person really doesn't want it on the same day, then you can separate it by about a week, I think, but it does mean 2 trips, unfortunately. So the safety of there's a note here, the 4th dot point there. The safety of the concomitant Fluad Quad and Shingrix has not been studied. However, you can either, ATAGI statement is you can either give these on the same day, or probably preferable to separate the administrations for a few days. So in terms of some common questions, just to remind you, when we try and pivot from COVID to flu, if you're latex allergy, yes, anyone that's latex allergy can have the flu vaccine. They're all latex free. If you're egg allergy, yes, even if you're egg anaphylactic, you can have the flu vaccine. There's now many studies showing that egg anaphylactic people can have the flu vaccine with no real problems. It's usually just a single dose. Suppose if someone has a dose in April and then they're travelling to the Northern Hemisphere at Christmas time, they might want to get another dose before they travel. Pregnant women who had a flu vaccine, for example, in 2021, should still go on to get another dose before the end of their pregnancy this year. And there is an approach for those in the rare instances, those people have had the Guillain-Barré syndrome. There's a nice algorithm there that you can have a look at to show what to do if you do have someone who's had Guillain-Barré after the flu vaccine. So the next few slides really are just to tell you where you're up to from New South Wales Health. This is slides courtesy of Sonia Ennis from the Ministry of Health. In 2019, the pertussis uptake was 77%. Even though we had COVID the last 2 years, the pertussis uptake was still pretty good at 79% in pregnancy. The flu uptake also pretty good, went up in 2020 to 58.8%. So, you know, not too bad, but there's always room for improvement. I think we've had this issue where pregnant women are getting COVID vaccines, flu vaccines, and pertussis vaccines, and it's a very crowded space during pregnancy. These are showing you different LHDs, and so they're de-identified, but you can just see the range across the state. But importantly, there was an improvement from 2019 to 2020 in each of the LHDs. Some of the lower performing ones are at the 40% mark, and some of the higher ones for flu are in the mid-70s. Pertussis is better. You know, the coverage there is sort of around about the 80% in 2020. So that's quite good. And the 2021 data is still being looked at by the Ministry of Health. One of the problems, I suppose, as you all know, is that we can't really get off the air the pregnancy vaccines. And the other issue is that some women who got a vaccine in private practice by the obstetrician or primary healthcare or pharmacy, they may not have had their vaccination status recorded on e-maternity. Okay. So we can improve that by making sure that the maternity services try to actually capture the vaccination records, particularly when it's given both within their service and trying to chase up if it happened outside the service. And as you all know, the vaccine recommendation by an antenatal care provider is a really important recommendation to keep the coverage up. All right, so changing topics again, just to go to Japaneseencephalitis. Now, this may not be a major concern in the central and south, eastern Sydney region, but it is certainly a massive issue for Australia, and it has become a significant, communicable disease of national significance. So the JE virus is a mosquito-borne, so it's one of the other zoonotic infections. Travels usually in water birds, and pigs are the amplifier for it. And what happens is that the mosquito with the JE virus bites the pig gets that virus. Some of the pigs that are pregnant will lose their piglets, but the virus will replicate within the pig. When the mosquito bites it again, it's able to, basically amplify it. So there's lots of concern about the areas around the piggeries in Queensland, New South Wales, and in Victoria. Infection in humans is often asymptomatic or can be mild, but it can cause a very severe disease, and that includes an acute encephalitis, which is devastating and for which there's no treatment. So as I mentioned, it has been found in the commercial piggeries in the eastern states. The highest infection risk are those that are living or working close to piggeries, particularly the piggeries that have tested positive for, and then also those that, camp, hike, fish, etc., near the piggeries where the mosquitoes tend to fly about 5 kilometres in a region of about 5 kilometres outside of the piggery. So importantly, the mosquitoes aren't flying hundreds of kilometres. The concern is, of course, that the because of our large wild pig population, that the mosquitoes will be biting the wild pigs, and then we really haven't got any ability to control it because the wild pigs just roam across the states. This is new, very, very new for Australia. It was really only found in the Torres Strait, but is now, as I said, a major issue. But it's not new for Asia and parts of the Pacific. And they've been dealing with these sorts of epidemics for many years. Usually the diagnosis is made from levels of antibodies, either in blood or CSF. As I mentioned, the encephalitis is nasty, and if you do survive it, you have about 50% will have neurological problems, and it's got a very high case fatality rate. And unfortunately, there is no specific treatment for the virus. The most important thing to do is to avoid mosquito bites, try to use personal protection, and both the Department of Primary Industries and Health is working together at a state and a national level to look at what can be done in an environmental way. And now there are 2 vaccines available, and the people that have now been prioritised for the vaccines. Those that work at, reside at, or have a non-deferrable visit to a piggery, and that includes people like transport workers, vets, etc. Those are also working in a pig abattoir or pork rendering plant. So that's the priority group number 1. Other ones are those that are working through mosquito surveillance, such as environmental health officers, etc. And those working in laboratories who might be exposed to the virus. So they're the 3 high-risk groups for vaccination. The government is ordering 100,000 or plus doses to come in, but at the moment there's not that many doses around in Australia. So it is coming. I don't know exactly when it's going to be coming. All right, so that's a bit on JE. Oops. And just to think of other vaccines, these are some slides that, again, you won't be able to read, but there's a whole lot of information out there in table form that you can get access to through the health.gov.au website. Just to remind you that those people that have medical risk conditions, and again, you won't be able to read it, but just to take home message number 3 or 4, if you do see someone that you know has a medical risk condition, just remember about the other vaccines, particularly pneumococcal, which I'll talk to you about. And also Aboriginal and Torres Strait Islander population needing extra doses. Again, just to remind you, there's a whole lot of information in the handbook about those people that need pneumococcal or meningococcal vaccines. Splenic patients, those that have hyposplenism, recommended extra doses, particularly of pneumococcal, meningococcal vaccines, the MenACWY and MenB, and also Hib vaccines. Those people that have had HEMAP bone marrow transplants, again, are also recommended to have extra vaccinations. And so I just want to touch a little bit on the pneumococcal story. There has been a change down to upwards from 65 to 70. So particularly those that got over the age of 70, the data, epidemiological data, was suggesting that you were much more likely to have pneumococcal disease, particularly in bacteremia and pneumococcal pneumonia. And so that was why the 13-valent vaccine was put in from the age of 70. That the effectiveness of the vaccines waned over time, so we wanted to have the vaccine still working at a time point when you were more likely to be getting nasty disease. And that's what that point there says, that from vaccination from 70 means that when you enter that high-risk period of nasty pneumococcus with a vaccine that's still working. The 13-valent pneumococcal conjugate vaccine does give you very good protection against bacteremic and non-bacteremic vaccine. So there's a Pneumosmart vaccination tool, which is quite a useful tool to help you remember which ones to do. And there's a whole lot of information both on the NCIRS website and in the National Immunisation Program, a flowchart. So a couple of sort of practice point reminders. Can someone have 13-valent pneumococcal, Zostavax and flu vaccine at the same time? Yes, you can have the 13-valent, the Prevnar 13. You can give them all at the same time when they turn 70. Can someone who's older than 70 access the Prevnar 13 even if they've already had the Pneumovax 23? And so the answer there is yes. A single dose is funded for those turning 70 after July 2020. For those who previously had the 23-valent pneumococcal vaccine, we try to give at least 12 months after that before we go and give you the 13-valent Prevnar 13. And those who are already over the age of 70 can just be given the Prevnar 13. So that's the pneumococcal, just reminder. In terms of shingles vaccines, there are now 2 vaccines available for use in adults over the age of 50. There's the Zostavax, which is the one that you know of and is NIP funded. It is a live attenuated vaccine. So we've had a couple of calls in the last few weeks to our immunisation service where immune suppressed people were inadvertently given the Zostavax, and we don't want to do that because there's a risk that they could get disseminated varicella. And it sets off a chain of decision making about whether to give Zostra immune globulin or valacyclovir, etc. So that's the main thing. Take home point number 5 or 6. Zostavax, just to remind you all, don't give it to the immune suppressed people. Shingrix is the adjuvanted recombinant vaccine, and it can be given to immune suppressed people. It does require 2 doses, but there has to be an interval of 2 to 6 months. It's on the private script only, though, and it is quite expensive. So that's there's a nice ATAGI statement there about the use of the Shingrix and Zoster vaccines. So that's it from me, Brooke and Brendan, and I'll stop there. And if either happy to think about any questions, or perhaps you want to talk. I'm not sure.
Oh, no, I'll definitely let you talk. Thank you for that, Nick. That was fabulous. Very interesting. Lots of things to look at. We do have a few questions that have been popped through to the chat, and I'm sure more will come through once we start asking. So I'll hit you with the first one if you're ready.
Yeah.
First question was in regards to Novavax. Any news on boosters using Novavax?
So Novavax can be used as a booster dose. The preference is to use the mRNA vaccine, the Pfizer or the Moderna, but Novavax can be used as a 3rd dose for those over the age of 18.
Okay, thank you. Can you comment on the latest data about when ATAGI may recommend a 4th dose? And this is for the non-immunized, non-immunocompromised, sorry. So I guess a second booster.
Yeah, no, that's a good question. I don't know what they're going to do, to be honest. For Israel, as far as I'm aware, Israel is the only country that's giving a 4th dose, and they had been prioritising the high-risk populations. I suspect that might be the first group that ATAGI goes with, the high-risk people that have had 3 doses and it's been several months since their 3rd dose, and that might be either age-related, because the bulk of the deaths still remain in the elderly. I don't think right now they're going to be saying to healthcare workers you need a 4th dose. I think it'll be more the medical risk conditions. I know they're looking at it, but I don't know exactly when they're going to decide.
Okay. No concrete inside information there. Have there been any instances of patients in the Northern Hemisphere having the flu and COVID at the same time, and how would we handle that situation?
Yeah, it's a good question. I think that's what Norman Swan or someone was calling flu-rona. Now, and that was the concern. I don't know, to be honest, if there have been dual infections. I know there have been people that have had COVID and bacterial infections, COVID plus pneumococcal, etc. So yeah, I think it's would be, and we do see children that have multiple respiratory viruses. I suspect the two viruses competing in your body, one might outpace the other one, and so it might not allow it to dominate, because remember the two viruses, you're the host for that virus that wants to replicate, so it wants to have a competitive advantage. So yeah, I don't know, to be honest, if there have been both flu and COVID. I think the concern is that people get COVID and they're unwell for a couple of weeks, and then they go and get flu, and their lungs are getting flu when they've had a bout of COVID and possibly damaged as well. So the double infection could well be the problem.
Sounds like you'd have a great time as a host for those two.
Yeah.
Okay, next question.
I know there was a question, sorry, that we were asked beforehand about how long does the mRNA and the lipid nanoparticle from the mRNA vaccine last in your body? So this has been looked at, and it is all available, although to be honest, it is buried in some of the regulatory documents by the FDA, the EMA and the TGA, which are the big, well, TGA is not big compared to the FDA and the European Medicines Authority, but they've looked at that particular question, and as you know, mRNA is very fragile, and that's why it has to be kept at such cool temperature. So once it gets into the body, it gets translated into the protein, usually very closely in the lymph nodes, in the site where it's injected. But then the mRNA is fragile and pretty much gets broken down by the body after a few days. So mRNA doesn't hang around for weeks and months and years. It certainly doesn't get transcribed into your host DNA. Now, the spike protein that gets made also hangs around for a little while. And the purpose of the spike protein that's made is for the body to recognize it as a foreign protein and to make the antibody. But the body also breaks down that protein. So the spike protein that's made by the body in response to the vaccine also breaks down. So you might hear stories from the anti-vaxxers that once you've had this vaccine, it stays in your body for life and you never get rid of it. That's not true at all. As you would expect, if you get COVID, that's got much more COVID spike protein in it than the vaccine ever has. And you don't have that COVID spike protein hanging around in your body forever, because you're basically, your body just destroys the virus. So that I know that was a question that was asked pre the webinar.
Thank you. Just jumping back over to shingles. If someone's had chickenpox at a young age and they're now over 50, would you recommend vaccination against shingles?
Yeah, it's a good question. I probably, it probably fits me. I'm over 50 and I had chickenpox.
Well, you can't have shingles without having had chickenpox.
Yeah. But I think it's probably, I mean, I think I would probably wait a little bit longer, not just hit it right at 50. I think it might be better to, wait to 65, 60, something like that, because you're more likely to get it the older you are. And so you want that vaccine because it essentially just boosts your immunity to be working closer to the time that you're going to get the shingles episode.
I'm guessing that question was related to Shingrix is recommended from 50, isn't it? Whereas Zostavax is on the NIP at 70.
Yeah.
Okay.
Right. So I just saw a point there that someone in the chat had said the spike protein has been found in liver cells for up to 3 weeks. Yes, it has, but it gets carried through the bloodstream into the liver cells, but then the liver is sort of the cleanser of the body, and it breaks down that spike protein. Now, the spike protein, in some sense, hanging around is not such a bad thing for a little bit, because it continues to stimulate the body to make antibody.
Right. Another question on shingles, keep them together. How long after contracting shingles disease can you then immunise against it?
We tend to say wait a year.
A year. Okay,
Yep.
year post-infection.
Yep.
Okay, back to, oh no, still on varicella, sorry. Some parents are asked about a second dose of a varicella vaccine for their kids. Can you give some suggestions of how they speak to them about it? I understand the NIP is for one.
Yeah. So the
dose, but
NIP,
two are recommended.
NIP funds one dose, but there's a note in the handbook to say that 2 doses is better than 1. And so I think, you know, if you want to optimise your protection against varicella, then yes, you could give a second dose after you've, you know, had the MMRV at the age of 18 months. The second dose at some point after that will give you optimal protection. The US is sort of promotes or recommends a second dose of varicella. So,
are there particular groups you recommend that to, as opposed to just a blanket?
Because it's a live vaccine, we can't give it to the immune suppressed kids, but certainly those that are chronically medically unwell but not immune suppressed, like all these things, are the ones that suffer the worst if they've got a varicella, you know, or any sort of infection. So they're probably the ones that you'd be targeting most.
Okay. On pneumococcal, why is Prevnar 13 preferred than Prevnar 23, even though it comes, even though it covers more strains?
So yeah, so Prevnar 13 is sort of a newer technology. So the old Pneumovax 23, yes, it has 23 serotypes in it, but it's a polysaccharide vaccine. So it doesn't have the conjugate vaccine technology that Prevnar 13 does. So what we find is that the antibody response with just a straight polysaccharide, which is basically sugar, string of sugar, is not as good as if we have the protein polysaccharide conjugate vaccine. So they are working on Prevnar 15, Prevnar 18, Prevnar 21. So that's in the pipeline, but you know, it's a better vaccine. It gives you a better immune response, both antibody and also cellular immune response. So it's a bit of a trade-off with less serotypes, so 10 less serotypes, but the 13 that are in there are the ones that are more likely to cause the bacteremia and the pneumococcal pneumonia. That's why they were put in the vaccine to begin with. So I hope that sort of answers it.
Thanks. There's one here, I'm pretty sure you've answered this, but just to confirm, the flu vaccine can definitely be given on the same day as the COVID vaccine.
Sorry,
that's a confirmation of double checking.
Right.
Someone's got that one in there. And you recommend different arms, is that correct?
Yep.
Okay. I feel it's important to make sure people are clear, especially if someone has missed it. Others may have missed it too. Apologies, just read a chat. Someone's chatted in the question section. If someone's on antivirals for recurrent herpes simplex, will shingles vaccine work?
Yes, is my understanding. Yes.
Is Zostavax booster recommended?
They're just a single one for Zostavax. Single 2 doses. Yep.
Okay. Here's an example question. A patient had 2 doses of AstraZeneca, got COVID 5.5 months post their second dose, and again 11 weeks post their first infection. When to get a booster, and is there a preference to Pfizer or Moderna? So I guess they've had 2 doses of AstraZeneca, they've then had COVID, and when should they get a booster, and should it be Pfizer or Moderna?
Either could be given, Pfizer or Moderna. I think I would be waiting at least 3 months after probably 4 months after their COVID infection. So they had 2 AstraZenecas, got COVID. I'd probably wait 4 months and give Pfizer or Moderna. There's no preference really.
So
Moderna's a 50 microgram dose and the Pfizer's a 30 microgram dose. Now you can't quite compare the different antigens because they've got slightly different lipid nanoparticles that they use. So it's not like one. But Moderna is a bit more, if you like, a higher octane vaccine compared to the Pfizer, in that it's got a bit more likely to cause side effects. So that's why the ATAGI statement particularly talks about the fact that, you know, Moderna might be more likely to cause some side effects compared to Pfizer.
Okay. Is a combination of 2 primary dose AstraZeneca primary course and a Pfizer booster better than 2 Pfizers and a Pfizer booster? So
no, it's probably two AstraZenecas and a Pfizer compared to 2 Pfizers and a Pfizer.
Yes.
I think that's what they're saying.
Yes.
The 2 Pfizers and a Pfizer is marginally better, but then this is based on antibody studies.
Mm-hmm.
And so, and you can also see, I think I showed you before, a little bit on the vaccine effectiveness against Delta and Omicron. So it is better probably to have had 2 Pfizers and then a Pfizer booster than it is to have had 2 Astras and a Pfizer. But we didn't know that at the time we were rolling out AstraZeneca. So I think what's probably happened is that lots of the early adopters, so the over 60-year-olds that had 2 AstraZenecas, I'm sure they've probably all gone out to get the Pfizer booster. And I think I'm not sure whether Brendan showed it, but the booster coverage in the over 70s is pretty good, better than in the under 50s.
Yeah, they got a bit relaxed once the pubs have opened. They've stopped going. Another question: a 6-year-old had their first dose of Pfizer and are now due for their second dose, but they contracted COVID. How long should they wait before getting their second dose?
Yeah, again. So I think the first thing is you don't want to give them another dose until they've completely recovered. And I think ATAGI says 4 to 6 months after their infection.
Yeah, I believe you can delay it for 4 months,
but
it's more that when do you recommend it? If the parent says, I know I can wait 4 months, but when should I wait?
I would probably still wait 4 months, to be honest.
Okay, is there a reason?
The reason I think is you've sort of had a dose of vaccine, you've had natural infection, so you've sort of already had your 2 doses. Yep. If you think infection is equivalent to a second dose,
mm-hmm.
and then the third dose is sort of, we're giving the booster dose at that 3 to 4 month mark now anyway. So that's why I just sort of think of the infection as a dose.
So you're getting the most value out of getting that booster.
You
may as well not waste it during the time when you've already got coverage from your infection.
Yeah, that's right. Yeah.
Okay.
Now, of course, if we don't have a whole thousands of children that are in that particular scenario compared to those that have had infection and the dose to compare the recurrence of infection. We just don't have that data available. So I sort of think of the infection as a dose of a vaccine, which is sort of what it is. It's a natural boost in your immunity. And then I think the simplest thing is to carry on from there is if you follow the timing for a booster dose.
Okay, and you'd apply that same theory to adults as well, not just kids.
Yeah, I would, but I don't know if I'm going to get into trouble for that. But to me, that sort of makes logic because
the official guidelines say that's okay, so it's okay.
I think some people, people would say, well, you're telling me to get a vaccine now when I'm just recovered from the disease that the vaccine was going to prevent me from. And I think that might be part of the reason why our booster uptake is lowish, because not many people are infected, mm-hmm. and therefore they're deferring their booster dose.
Yep. Which makes sense when you explain it as effectively an infection is a dose.
Yeah, that's how I sort of conceive of it. Yeah.
Another question about dosage. A 10-year-old got their second dose of Pfizer and then tested positive for COVID 4 days later. Will this impact the immune response in a beneficial or negative way?
That's a good question. I don't know the answer to that, to be honest, because they've probably hopefully got a milder form of the COVID infection because of their first dose. The second dose may not have really done much if, they might have been exposed while they were getting that second dose of the vaccine and then got sick 4 days later. So the second dose vaccine probably won't have really had enough time to, work to stop them getting sick. But hopefully the first dose made the infection milder. So it's hard to know immunologically what will happen. You're being exposed to the COVID antigen, both from vaccine and from natural COVID. So you are making antibody, or you are making cellular immunity. It might well be that you've got a broader immunity because you've had the disease, and therefore you might have longer lasting protection, but we just don't know the answer to that.
Okay. And I think that's all the questions. You can rest.
Thank you.
So thank you, Nick. I've just got a few things that I'm going to say about a few, but if you wanted to hang around until the end, if that's possible, just in case a few more really good ones come through, and we'll ask them at the end as well. So I'll share my presentation now. Okay, so as you know, you've already met me this evening. I'm Brooke Willoughby-Thomas, part of the immunisation team. And again, we have Kira and we also have Mimi. They've been busy in the background. If you've checked that chat, Mimi has been putting a lot of information in there for you, lots of really useful links about what Nick has been talking about. And I'm just going to take you through a few things that we can help you with in regards to everything that was spoken about tonight. So firstly, if you haven't already heard about the fabulous new report, it was a long time coming. It was released at the end of last year, and that is called the AIR 42A report. And it is the bee's knees of COVID reports that we can get out of AIR at the moment. And it's now being upgraded even further. It's had a bit of a booster of its own, and it now offers 3 different things that you can get out of the report. You can pull a report of patients at your practice that have had no COVID doses. You can pull a report of patients that have had only 1, so you can chase them up for their second. And you can also pull a report based on their booster, if they're due or overdue for a booster. And this report can be broken down into any age range from the age of 5 all the way up to 100 and whatever there are in the world. And the way that patients are listed on this report are linked to an MBBS service period. And what that means is if a patient has attended your practice for anything, sore nose, sore toe, in the last, say, 12 months, if that's what you select, they will come up on this report if they're due for any of these things in regards to a COVID vaccine. So it's a COVID specific report. Now there is a handy guide that we have on our website, and I might get one of the girls to post a link to that guide in the chat on the off chance you're desperate to look at it this evening. But otherwise, we are more than happy to help, and you can email us, you can phone us, we can do a team viewer where we kind of jump onto your computer and show you live, or we can just walk you through it over the phone. But any questions at all that you have, you can ask. And I must say, I'm impressed with AIR. It's a fairly user-friendly report. It makes sense when you open it up. You don't open it up and then think you need to go to an Excel course to work out how to interpret it. It's all pretty straightforward. So we highly recommend that you run that report. Now, the other reports that have been around for a very long time, and I won't go into them tonight other than to mention them, is the AIR 10A report, which is a due overdue report for all your other vaccines. So that's your NIP vaccines. It does not include COVID. It includes everything else. So that's when you're looking up kids who are overdue, and they're on that report in the same way, linked to an MBBS service period. That one is for accredited practices. So you'd need a PIP ID. Now your AIR 11B report is the one that you would use for your overdue kids for NIP vaccines again, but it's provider based. So if you're not an accredited practice, you can bring this one up. Now, if you need any help on those two, of course, call us, email us, check our website again. And just to remind you, easy email, immunisation@cesphn.com.au. Now, just touching back on our rates in our area for the 5 to 11-year-olds, because it's quite concerning. We know that there's probably a few assumptions in there, like everybody was super busy and got in and booked their appointments right at the beginning when the vaccines came out. It was school holidays. There was a lot more flexibility for parents to get their kids in there. Also a lot more flexibility for parents to manage the potential symptoms that come from a vaccine. I've got 2 little kids of my own, and I certainly wanted to get it done before school. But now that school has started, either the majority of those children have been infected from school or at the end of the Christmas holidays, or the parents are just too busy. So we're hoping that there is going to be a rush for vaccines in the school holidays. You've got about 2.5 weeks before school holidays hit. You've got 1 week of those school holidays before Easter hits. So now is the time for you guys to be focusing on getting those 5 to 11-year-olds booked in so they can start winter and start term 2 at school with a second dose, or even if they haven't had any, a first dose. And again, it's these suburbs or LGAs at the bottom here, the Georges River, Bayside, Canterbury, Bankstown, that we really want to focus on. And of course, all the others as well, to chase up the extras. Now, how can you do that? One of the easiest ways for you to do that is to run an AIR42A report. And you'd requested for 5 to 11-year-olds. That will bring up all children who have visited your practice for an MBS service item in the time period that you select. We recommend, say, 12 months. It means you won't get kids who came 5 years ago. You won't get those kind of kids on there, so and have only come once. Then we'd suggest maybe you set up some clinics if that works for you, if your practice is large enough that you could run a clinic. Why don't you make it a bit fun? I know from personal experience with kids, if dose 1 goes well, kids are more likely to, and parents, line up for dose 2. I know the state vaccine hubs have been big on giving kids prizes, certificates, stickers, show bags, balloons, all sorts of things. Unfortunately, they haven't provided that in the general practice setting, but we have so far been encouraging you to maybe make your own certificates or maybe create a balloon. We're hoping that CESPHN might be able to provide you with a bit of a certificate template. So watch this space, keep an eye on the immunisation news, and we might have something fancy for you that you can just run off and print and hand out to your kids. So maybe think of a clinic. Make sure you're maximising all the doses within your vial, because I understand that some practices are maybe a bit concerned about opening a vial up for only 2 patients. So a clinic might help. And then contact your parents once you've run your report. Get all those kids in. Remember, you've got that Sky resource there for sharing knowledge about immunisation if you need some assistance with talking to parents who are hesitant or might need extra information. And at the end of the day, we're hoping, with a sunny disposition, that we have jabs in our arms and that we exit the school holidays with a much higher rate of 5 to 11-year-olds vaccinated and ready to hit school again, and hopefully not capture the flu. So at the same time, yes, you might have some hesitant parents in there, but for those who maybe just put it off because they were busy, really good opportunity to get the flu vaccine in. If that's in practices by the start of April, so upsell that one as well. I understand that kids over the age of 5, if they don't have underlying medical conditions, may have to pay for that. But we hope that you can maybe do some talking to the parents and get them done at the same time. Get them both in, or at the very least, vaccinate the parents at the same time with the influenza as well, and get those kids back on a recall for that. And use those Sky resources to help talk to the parents who are hesitant still. Now on cold chain management very quickly, we just wanted to remind all practices that the online cold chain management course, otherwise known as the HETI course, is for everyone in your practice who is associated with vaccines. That's not just the nurse giving the jabs in the arms or the GP giving the jabs, the person at the front desk who receives the vaccines, the person who does the ordering of the vaccines. It's often the receptionist who receives that box. If she receives it and the nurse isn't there, or he, we want to make sure that they know exactly what to do with those things. And also, if someone's away and they're responsible for checking the fridge, they need to have that cold chain management understanding. It takes about 45 minutes to do the course online. So we do strongly encourage all practices to have all relevant staff complete the HETI course. And the cold chain management thing that we wanted to discuss was, do you have the best data logger you can? Now, I'm sure all of you have a data logger. It's mandatory in New South Wales and now the whole of Australia, and has been mandatory for quite a while. But do you have the best one you have? Do you have one that you have to walk to the fridge, unplug, take it out of the fridge, go back to the desk, hope you don't get distracted with a phone call, plug it into the computer, download the report, hope you don't get distracted with the patient, take it out, remember to turn it back on and put it back in the fridge. There are so many spots in there for human error. You could have a data logger that reports are automatically emailed to you. You could have one that gives you alerts on your email and your phone. straight away if something is wrong, and that you can check in on any time, anywhere in the world. You can go and check in on your fridge. These are called wireless data loggers. There are a lot of them on the market. We can give you a lot of help on that. There's information on our website. They are so user-friendly now and quite cost-effective, and they take away human error. Everything is done automatically. Nobody has to every week go and download it. You're required to review it every week, but that's a really simple thing that you can do anywhere, anytime. And the most important thing is the alerts that you get sent to your phone. So if someone leaves the fridge open at the back of the practice, you will get an alert on your mobile phone before it turns into something that becomes a cold chain breach. So again, contact us, check out our website and have a look at that. And lastly, just some information for you. Again, really easy email addresses: coronavirus@cesphn.com.au. Practice support team, we've got a great team of people that can help you there as well for everything, things like accreditation, all that kind of thing. And they're also very, very heavily involved in the coronavirus support. Practice support@cesphn.com.au. and the immunisation team, immunisation@cesphn.com.au. I don't have time to take you through our website this evening, but please take the time to have a look through that, particularly the immunisation page. Everything is on there that you could possibly need. And always use the search function. If you get a bit lost, just type it in the top. I'm going to leave this slide up here for you to look at. Some more great webinars that are coming up that are run by CESPHN. Again, you'll find them all on the CESPHN website and the events page. At the end of the webinar, please don't forget to complete the evaluation form for us if you can. If not, the email will come to you in the next day or so, I would assume, from our CPD team with a link to the webinar as well, and the recording, as well as the evaluation form. I believe there's nothing more for this evening, so I'd like to thank everyone for attending. A special thank you to our speakers, to Dr. Brendan Goodger, Associate Professor Nicholas Wood, and I hope you all have a lovely evening.